Good afternoon and welcome to the 6th edition of our Future Leaders Speaker Series. My name is Jocelyn Bellerud and I serve as co-chair for the St. Paul's Foundation Future Leaders. It is a privilege to join you from the traditional unceded territories of the Semiahmoo First Nation. For thousands of years, this beautiful place has been stewarded by the Coast Salish peoples, including the Kwantlen, Katzie, Semiahmoo, and Tawasin First Nations. I am a grateful visitor on this land. In the spirit of humility and reconciliation, I am learning about the barriers faced by BC's First Nations, Inuit, and Métis peoples as they navigate a healthcare system that is shamefully steeped in anti-Indigenous racism, discrimination, and stigma. This work is a journey. I invite you to join me on a path towards reconciliation, cultural safety, and wellness of Indigenous patients and families across BC. Today's program focuses on Indigenous-specific racism in healthcare and the path forward. We are fortunate to be joined by Harmony Johnson, Interim Vice President, Indigenous Wellness and Reconciliation at Providence Health Care, and Sherry Hunseth, Director, Indigenous Relations and Community Engagement at Providence Health Care. This forum offers the opportunity to learn and explore how we can improve our accountability and share best practices to bring leadership and a spirit of reconciliation to our homes, peer groups, and workplaces. We encourage Q&A at the end of today's session. Submitting your questions is easy. Depending on your device, the Q&A box may be located to the right or below your viewing screen. Type your question into the box and hit submit. If you see a question you are interested in, you can upvote it by clicking the small arrow to the left of the question. You may submit your questions as you think of them. There's no need to wait until the end. If you wish to make a donation after today's speaker series, you may do so through the QR code, which we will put up on the screen at the conclusion of the presentation. The donations that we receive today will support Indigenous wellness and reconciliation across Providence Health Care. I would now like to introduce our first speaker, Sherry Hunseth. Sherry is Métis and was raised in the Wood Buffalo and Lac La Biche region of Northern Alberta. Sherry is Director of Indigenous Relations and Community Engagement at Providence Health Care. Her role focuses on establishing and strengthening relationships and creating opportunities for community engagement with Indigenous patients, families, and community members. Sherry's goal to improve Indigenous cultural safety and to amplify Indigenous perspectives so we can improve health outcomes for First Nations, Inuit, and Métis people today and as we move towards the new St. Paul's Hospital. It is a pleasure to welcome Sherry Hunseth.
Thank you so much for your introduction, Jocelyn. To start today, I would like to respectfully acknowledge that the land I'm privileged to join you from today is the traditional and ancestral unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh. I am very grateful for the privilege to do my work and to reside on these Indigenous homelands. I'm also very honored to have the opportunity to introduce you to Harmony Johnson. Harmony is currently the Interim Vice President for Indigenous Wellness and Reconciliation at Providence Health Care. Harmony is of Slamon First Nation ancestry and was raised in the Slamon territory where most of her family resides. Harmony has served in many senior roles with the In Plain Sight Review in BC Healthcare, with the First Nations Health Authority, First Nations Summit, and the First Nations Forestry Council. Harmony is the author of a number of publications, including the book Written as I Remember It, Teachings from the Life of a Slamon Elder. Harmony is currently working for Providence Health Care and provides an Indigenous leadership perspective for the organization and has created the guiding strategy and work plan, as well as the policy direction for Providence Health Care. Harmony is dedicated to promoting reconciliation and addressing anti-Indigenous racism and discrimination. It's my pleasure to not only work with, but to welcome Harmony Johnson. Harmony.
Thank you, Sherry. Nothing more awkward than sitting through your own introduction. So I am joining today from Tsleil-Waututh territory. I have had the pleasure of living in these unceded lands of these beautiful people for most of my career. and have had the pleasure of working really closely with the nation and getting to know many of its members and consider them my close friends and family. I am from the Tla'amin Nation, as Sherry described. That is a couple of 100 kilometers to the north of these territories here at the northern end of the Sunshine Coast. And I'm here today in two capacities. One is I'm going to speak about the In Plain Sight review. I had the opportunity to direct that review on behalf of Mary Ellen Turpel-Lafond almost a year ago. It'll be a year at the end of November when we release the report. And I'm also here in my capacity as the VP for Indigenous Wellness and Reconciliation. So I've got a fairly tight time window here, so I'm going to try to get through a set of slides both on In Plain Sight, our methods, what we found, what we recommended, and then transitioning that to what are we doing about that within Providence and what we control at Providence Health Care. So if we can put up the slides, that'd be great. Just acknowledge that the artwork was for the review was done by a gentleman, it was important to us that we work with a youth, and his name is Elliot Hill from the Nanaimo Nation. And it was really wonderful to work with him, and he did these beautiful illustrations for us. So I always just like to acknowledge his work. I also want to acknowledge that our knowledge keeper for the review was Shane Point Silkson, who some of you may recognize from some of the work we have been doing at Providence. So it's been really wonderful that Shane has agreed to continue to coach and mentor me and support the work that we're doing at Providence. Next slide, please. So just a couple of kind of contextual things for the group. So if there are Indigenous people listening, I would just let you know that I am going to be talking about some difficult truths and experiences that we share, and that this can be triggering. And if that's upsetting, it's like you just step away, take care of yourself, access the many supports available to you through regional and national lines, message me directly. I'm happy to talk. For non-Indigenous people, there are typical feelings that are that we need to normalize as being part of this journey of learning and unlearning. This is as much about unlearning what we think we know as much as it is about learning new facts and learning new truths. And that's an uncomfortable process. Often I see feelings of guilt, of shame, sometimes of anger. Fragility is a term that's often used. Sad, people are sad. They're sad that they don't know that these truths exist. So those are normal feelings. Accept them. That's part of the process. That's a normal part of the process. It's unfortunate, but it's true. So just accept the discomfort, know that that's normal, and take responsibility for positive contributions. Don't get stuck in that space of feeling guilt or shame. The idea is transition that into a sense of responsibility. Next slide, please. Next slide. So just briefly on the method, I'm not going to take a lot of time on this, but for the In Plain Sight review, we had a bit of a mixed method of both primary data collection and secondary data collection and analysis. So you'll see on the left-hand part of the slide, these like tiny dots that are probably making your screen look weird. We did like kind of direct engagement with almost 9,000 people. We ran 2 surveys, one for Indigenous peoples, but we did have non-Indigenous peoples participate in that survey. So we kind of had a bit of an inbuilt comparator group. Then we did a health workers survey. We also had a direct email and 1-800 line, which by the time we did cutoff for the purposes of data analysis had about 600 respondents. Although by the time we wrapped up the review, that line is still open. Actually, the ombudsperson is running it. When I wrapped up the review, it was close to 900, I think, respondents. And then we did about 150 key informant interviews with individuals across the system, patients, families, others. Then we did a whole bunch of data analysis, first of its kind type of work. So we did some data matching that enabled us to look at the health utilization data and outcomes of all First Nations and Métis registered folks in BC. We used a bunch of data from existing surveys that collect self-identification data from Indigenous peoples. And for the first time, we pulled Indigenous complaint files from the patient care quality offices, the regulatory bodies, and the First Nations Health Authority, and that had not been done before. And then we did a lit review. So all of that evidence kind of pooled in together and informed the final report. Next slide, please. So one of the meta findings of the review is essentially that we don't have a common language for working in this space. And in some ways we use the same words, but the words are kind of either people have emotional reaction to some of the words, which kind of prevent us. It's like this force field preventing us from solving the problem because there's like a reaction, an emotional reaction to certain words. And or some words are kind of almost like they become like a motto or a slogan. And so people are using certain terms in a very general way. And like when probing, what does that mean? What does that look like in practice? What's the definition? How are we measuring that? It kind of quickly falls apart. So it was important for us in the review to create a clear set of terms and to put those terms in some sort of logic model with each other. Like, what's the problem? What are ways we can solve the problem? And towards what ends? What outcomes are we looking for? So starting on the left on the issues, these are like the kind of problem statements, right? Racism, a social process that creates a hierarchy of people based on cultural background, skin color. This is has no like basis in genetic reality. It's purely a social process. And it is both interpersonal between people, that like racism can happen between human beings, and racism can also happen in systems, right? Policies, structures, institutions can create racism and perpetuate racism, which is kind of systemic racism. And there's forms of racism that are very unique to Indigenous peoples and that have their roots in our colonial history here in British Columbia. And I'll talk a little bit about that in a couple of slides. Now, racism, this kind of beliefs about a set of people based on skin color or culture, lead to like profiling and prejudice. So a profiling is like you see somebody, you have a preset image or a preset set of beliefs in your mind, and that kind of immediately that individual is colored with that profile. We use this a lot in the kind of justice system, right? And so Mary Ellen, as like a renowned lawyer, judge, legal scholar, was certainly recognizing, well, this is profiling. And profiling leads to prejudicial behaviors, actions, treatment, which is discrimination. And I'm going to talk about what all that looks like specific to Indigenous people in healthcare in a bit. The ability to not experience any of that, the ability to not have to think about this 24 hours a day, 7 days a week is privilege. So what you can see on the slide, there's like a quote that is pulled from the review where there's this non-Indigenous dad and he's married to a First Nations wife. They've got kids together. And he called us and was like, I always take the kids whenever we have an appointment or whenever we have to go to emerge because I'm white and we definitely get better care when I take the kids than when my wife does. So like that's privilege, right? He's using his privilege. Me, I'm a Muslim person, but I know that I'm white passing, right? Privilege for me, that's privilege. Like I can say, when they ask me, are you Indigenous? I can look around, I can kind of feel it out. I can be like, is it safe for me to say yes? And if so, then I will. That's privilege. And so it's part of my responsibility to use that privilege to support all my other family members who aren't white passing and can't, that don't have that choice, whether to kind of experience racism or not. mindsets, practices, and tools. These are what the solutions are to address these issues that I just talked about, right? So to me, anti-racism and cultural humility are kind of like hand-in-hand concepts. So anti-racism is a very active practice of saying, like, I dislike racism and I am taking an active approach to oppose racism in all its forms whenever I see it, and to take active measures against racism. People often will think, well, you're either racist or you're not racist. And many others, I'm not like the one who comes up with this, like we don't think that's true. We think that you're either racist or you're anti-racist. And the benefit of anti-racism as a mindset is that it is a very active practice, right? It makes you feel like you're doing something, like you're advocating, like you're acting. That's positive. Cultural humility, why I think they go hand in hand, is that cultural humility is very much an inward-facing practice, right? Like you're reflecting on one's own cultural background and how that shapes your interaction with others. It's interrogating one's own biases. It is understanding and personally challenging yourself to say, is my worldview truly better than that? Like, am I having this sense that my worldview is better than that of the people that I'm interacting with? And really, truly looking for and reminding oneself of equal respect. So that's why I think those go together. One's active, one's kind of reflective. And what are we looking for? Well, we're looking for essentially Indigenous human rights. So what you see on the slide, I do a lot of work in the UN Declaration and its application in British Columbia. What we have here is Article 24 from the UN Declaration, which focuses on health. The way I think about it is that Indigenous human rights to health are the right to experience services without discrimination, the right to equitable outcomes, the right to self-determination, and the right to use one's own cultural and traditional and ancestral medicines and medical systems. So the Indigenous human right to health has those 4 components, and that really guided the outcomes that we were seeking and the recommendations of the review. And you'll see we purposely unpacked cultural humility and cultural safety, one being a mindset, one being an outcome, because in many ways, that was the slogan, right? Cultural safety, humility, cultural safety, humility. We're like, that's great. Like, people are using the right words, but we're all using them in different ways. Next slide, please. So in terms of the surveys, what did we hear about racism? 84% of Indigenous respondents reported some form of discrimination. 35% of all respondents to the health worker survey had witnessed interpersonal racism or discrimination to Indigenous people. And amongst Indigenous respondents, who would obviously be more sensitive to seeing and recognizing and knowing what racism looks like, almost double had witnessed that as Indigenous healthcare professionals. Over half of Indigenous healthcare workers said that they had experienced racial prejudice at work. I can certainly attest to that. That can range from really kind of overt things that we would all think about when we think about racism, right? We think about it as like an overt name-calling pejorative thing, when really racism comes in many forms and can often be the just people thinking you're less capable because you're Indigenous. Like, that's the one I get all the time. And we got over 500 racist comments in the survey, and of course, much more by email. Many of them are the things that you're thinking of, right? Like the kind of horrible things that come to mind when I say, oh, we got a racist comment. But also many of these were like, almost like I can recognize racism elsewhere, but I don't necessarily recognize it in myself. So for example, people might say, well, yeah, I saw an Indigenous person getting treated really rough at Emerge and being called whatever. But what do you expect when they all drink too much? Or, yeah, we saw this Indigenous woman and like people were kind of treating her badly, but what do you expect? They have so many different kids by so many different dads. So it's almost like explaining it away and not necessarily like excusing it, right? By using the same stereotypes. Why does racism persist? There was like high agreement on this. amongst healthcare professionals. Employees are not willing to speak up when they see it. Lack of accountability by leadership to stop discriminatory behavior, and we need more Indigenous healthcare professionals. So you can see this tension that we have, right, between people saying, well, racism persists because there's insufficient numbers of Indigenous healthcare professionals, yet you can see how the work environment in many ways can be challenging for Indigenous healthcare professionals if you're seeing racism, if you're experiencing it yourself. Next slide. So on solutions, we also asked, so not just about problems, but like, hey, like how do we want to go and fix this? So interestingly, both Indigenous patients as well as healthcare workers reported a lot of the same solutions. We need policy to stop racism. We need training and education. We need more Indigenous healthcare workers. Those were like really common themes. The difference, of course, like kind of relates to the unique experiences of patients relative to providers. So providers are like, we need leadership to promote this and make this kind of clearer to us as a priority and give permission and space to us. And then patients were saying, we need better ways to be able to complain and raise our issues. There was a significant lack of trust in the complaints process. Next slide. So I know that the text is small. I'm just going to walk you through this. This is really the main thing to take away from the review. And the thing that I've heard the most, I think, as a result of the review was like, oh, I don't think I realized that racism actually harms people. And that was surprising to me. And I think because I do a lot of work in the space, you kind of like take certain things for granted. So yes, like this racism is not just, it's not just rudeness. It has impacts at individual, personal, and population levels. And the racism that we see in the health system today has its roots in our colonial history. So if you start at the like 11 o'clock part of this wheel, you can see that we have Indigenous knowledge systems. We had our own health systems. We had our own medical systems here that supported our health and well-being. This was supported by our philosophy of health and wellness that like mental, spiritual, emotional, physical aspects are all what make us up as human beings, and that those are all part of our well-being, and that our well-being is in relationship with others, with our values, with our teachings, with our environment, with our ancestors, and that the well-being that we have is our legacy to future generations. And this kept us thriving here in this place since time began here. And that kept us well. And then colonialism, the systems of colonialism, which are the systems of oppression that are intended to subjugate Indigenous peoples and get access to their lands and resources. Like, how do you justify that, right? Like, how do you justify residential schools? How do you justify Indian hospitals? How do you justify the Indian Act and confining people to reserve and saying that they can't vote and they have to have a pass to leave the reserve, and we're going to take your kids and we're going to like expose you to medical experimentation and abuse? Like, how do you justify that? Well, it's justified through a set of beliefs that are cultivated about the inferiority of Indigenous people, right? So that they're bad parents, that our cultures are not developed, that we're not capable of governing ourselves, that we're dying off anyway. So those were all very common beliefs of colonialism. You could see this is the colonial narrative that was in all the newspapers and all of the policy debates at the time. And that was really the underpinning of our healthcare system and our society. And it's only, I would even say, like the latest recovery of bodies from residential schools tells me, the way that everybody reacted to that tells me that we haven't accepted the truths of the past and that maybe we're getting there. And that's a good thing. So we haven't accepted those truths and they are still very present in society. So when we looked at healthcare today, So we looked at all that data that I talked about before, right? All those surveys, all the complaint files, like all of the incoming complaints that we received. We looked at all the SANIAS, Indigenous Cultural Safety Education Training data. And these were the stereotypes that were common about Indigenous peoples in healthcare. Less worthy, right? Like just not as worthy human beings. Drinkers, alcoholics, and drug seeking, bad parents, frequent flyers, non-compliant, and less capable. Those things kind of go together, right? People can't take care of themselves or never compliant with medical advice, get stuff for free, or like advantaged somehow. This is a very common stereotype. And as I'm saying this, I know like these are not specific and only to healthcare, right? We hear this all the time in education and other fields about like free stuff and bad parents and all that stuff. And then there's this whole layer of misogynist views about Indigenous women, right? That we're more sexually available, that we have a different pain tolerance, squaw, these kind of words were used a lot. So I know I'm being like kind of aggressive with my words here, but these are the stereotypes that exist. So what happens with those stereotypes? Well, they lead to discriminatory care. So remember what I said about profiling, right? If you have a profile of someone, then does that shape your behavior and your interaction with someone? So abusive interactions, denial of service, ignoring, shunning, inappropriate pain management, medical mistakes, disdain for cultural healing, right? So if you're profiling someone as drug seeking, then they don't get prescribed. If they're drinkers, alcoholics, then you're diagnosing them as such and not recognizing it's a episode with diabetes or brain tumor. So I would also ask you here to think about like almost like pretend there's a dotted line across the wheel from discrimination to poor outcomes. That the very experience of racism has an association with poorer health outcomes. People who experienced racism and discrimination in the last 12 months also reported higher degrees of stress, distress, problematic substance use, etc. So the very experience of racism itself associated with poor outcomes. And if you carry on around the wheel, it also shapes access issues, right? If the environment is unwelcoming, like you don't want to go there. We see that there's systemic kind of discrimination. People are like have lower attachment to GPs and NPs. There's a lot of mistrust. There's significant avoidance of healthcare. And this is the thing that was most worrying to me. All of this shapes poorer outcomes. And yes, of course, there are many other factors and drivers, these kind of like determinants of ill health that are also impacting on these outcomes. But you have higher suicidation, increased rates and faster progression of chronic disease, higher infant mortality, all of these things that are typically reported actually on their own with no context. So sometimes we'll hear like, oh, higher infant mortality amongst, say, First Nations in whatever region. Well, unless that's reported within the context of truly what's driving that, then of course that just feeds a stereotype of bad parents, right? Because that's the profile that many are carrying in their minds. So it is important to illuminate the true source of the problem so that we can then target solutions. So I know I've spent a lot of time on this slide because this is the one that to me is kind of the report at a glance. Next slide, please. So I think I've mainly covered kind of what the problem is and what we saw, right? There is widespread and systemic racism and stereotyping that limits access to treatment. Women and girls are disproportionately impacted. What we saw was that public health emergencies in some ways magnify, right? That people experienced, Indigenous peoples had greater impacts from COVID and from the overdose public health emergency, and experienced, there was like blatant racism that was widely reported, right? That in my own community, when there was a COVID outbreak, it was like, you know, all these businesses in town saying like, you're not welcome here. Pretty blatant. And then healthcare workers and students face racism in their work and study environments. And then we looked a lot at the solutions, like the things that we've all been doing, myself included, for many years to try to address this issue, right? So what we saw is current education and training is is not having the result. It's moving too slow. It's not impactful enough. The programs that are there are not kind of longitudinally evaluated. It's not having the impact we need. Complaints processes are unsafe. Indigenous practices are not well integrated in the system, although that certainly has been getting a lot better. Insufficient hardwiring, et cetera. So in all of these, what I would say in all of the solutions, there are pockets of really excellent work happening across the entire system on this. But it is not itself a system, right? These things are not consistent across the system in a way where Indigenous people could expect to receive culturally safe care anywhere, anytime. Next slide. We also produced a data report. I'm not going to go into this in detail. I would just say that, clearly there's like an environment where Indigenous people are accessing most of their care in emerge, as opposed to like not in primary care. And that Indigenous women are shouldering the greatest burden of any population that we looked at in the review. And I will always kind of come back to that one because I think that's the one where it's been a real crisis for some time with very little, I think, focused systemic action. Like I said, great pockets of work happening in all sorts of places, but the need for more systemic solutions and interventions there. Next slide. So with all of that, we developed a total of 24 recommendations. The idea was, like, as I said, it was a real systems focus, right? So we had most of our recommendations was on systems. So, we need actual changes in legislation. There needs to be improvement in some of the governance structures that exist in health. Things that are propelled by the system, like standards, complaints processes, need to be improved. We need ways to measure all of this. We had a set of recommendations on behaviors. This is really focused on how do we have systems and organizations behave differently. So increased Indigenous leadership within the system. On that one, the system's made the most progress, I would say, with I think all the health authorities now having or recruiting a VP level position, and the Ministry of Health having a dedicated team on that. And so that will definitely make a big difference and has so far, with specific drill down efforts. So like I said, for women, mental health and wellness, and in these health emergencies. And then we focused 4 recommendations around beliefs, which really focused on education, as well as proposing some joint degrees in both nursing and medicine with Indigenous medicine. Next slide. So now my in plain sight piece is done, and I'm going to talk really briefly about the work that we're doing at Providence. So, after the review was done, I run a consulting practice. I'm happy with it. Like, I have clients that I love, and I'm doing work that I care about. And I was also really interested in, how do you take something like this report and actually try to apply it and make meaningful change for people? So, I had different maybe opportunities, I guess, to do that. Providence is interesting to me for a number of reasons. One, I think that its geographic and its service mandate is truly unique in a way that it's like a finite but high important and high acuity set of services and population base that is a high need. And there is a real opportunity to make impactful change and meaningful difference. I also think Providence actually does mean what it says when it says that we'll embed truth and reconciliation in everything we do. And that's been clear to me throughout my time here so far, from our board to everyone that's welcomed me, to Fiona. So that was attractive to me. And there are unique opportunities given the new St. Paul's, obviously, and the kind of Catholic sponsored nature of Providence creates a deeper imperative and some interesting dilemmas for us to work through together. And I'm interested in figuring out how our team can help support that. So in coming to Providence, obviously my interest was, well, let's create a plan and let's work together across the organization on a bit of a plan that helps us take in plain sight and make meaningful focused change. So, we have a draft that we're kind of working with now. So I can't kind of like go into a lot of detail, but I would say I'm excited about a few things. I'm excited about working with the host nations and Indigenous patients and engaging with them on the new campus and on creating an Indigenous Wellness and Welcoming Center on the campus as we recommended it in plain sight. I'm excited about expanding our Indigenous wellness team to provide complementary care services for Indigenous patients accessing services in our hospitals and long-term care and the other services that Providence runs. Our consults are increasing. There's more people accessing our services, and I'd love to continue to have that grow. I'd like to support Indigenous people to choose to work at Providence and knowing that they can be Indigenous at work, that we've got a place that is welcoming, that's identity affirming for us and for other people, other racialized people. And I'm interested in learning and innovation and research work. I'm interested in doing applied, focused Indigenous cultural safety interventions in sites of high priority, like emergency department, in other areas where we have a high number of Indigenous people accessing care from us. This isn't just about delivering 101 training. This is about working shoulder to shoulder with our colleagues to support us all to become more culturally safe and to learn about that and to lend those lessons across the system. So I really see that there's this opportunity through this action plan to position the work we do at Providence as a bit of an innovation hub for this work. Next slide, please. Just quickly on this wellness center, it's something I'm excited about. We're having lots of fun conversations about it. This is Salkson Shane Point, who I spoke about a little bit earlier, mentor of mine and a knowledge keeper for us here at Providence. And we had a really lovely blessing ceremony on the site. And he and I were actually able, and Sherry, were able to get onto the site just for a private blessing on Canada Day of all days, and did the work that we needed to do on the site. And then we had this gathering a few weeks later to explain that to everyone in Coast Salish law and protocol. So this was an important way of demonstrating that that this is more than acknowledging the land, but it's about honoring the protocols of the people that live here and whose land it is. So we see that this center can provide this real opportunity to welcome all peoples to the campus and provide a safe wayfinding and a safe space for Indigenous peoples, and serve as an entry point to the rest of the campus, which we're also really building in a way that reflects our teachings and our philosophies of health and wellness. Next slide. There's some positive change happening too. Like, this stuff can feel really overwhelming. I had a student, I teach in the space, and I had a student one year tell me that they felt the same about racism as they do about climate change. And it really has stuck with me for years that this person said this to me, because it's that feeling of like complexity, right? Like, what can I do with such a big problem? Well, we can do a lot, but it does take all of us doing stuff to really make that systemic change. And it is happening. So we see here, there's just like a couple of quotes, like one mom, her daughter, complex, has a lot of needs. She's often at St. Paul's Emerge and often leaves before she gets seen. And our team was able to connect with her and make her feel comfortable. And she was actually admitted, which hardly ever happens. And she had a good stay and was discharged and in a bit of a better place. And, the mom said, like, it is getting better. Like, my daughter was treated well. We had a good experience. Like, that's fundamentally what we want. Next slide. So this is my last slide. So I know I've been talking like totally fast for half an hour. I'm asked all the time, what can I do? So like I said, people get overwhelmed, right? It's too big a problem. What can I do? Well, we can all do something, and change happens in our own hands. And that's what this quote is getting at. So self-education, this is my number one thing, right? Like, what can I do? Read these reports, like read in plain sight, read the Truth and Reconciliation Commission report, read the Missing Murdered Indigenous Women and Girls report, read fiction, pick up novels by Indigenous authors, listen to podcasts. There is like lots of free stuff. Take the University of Alberta massive open online course, which is like a 101, and take it with a group of colleagues or friends and like talk about it. That is the best you can do. Self-educate, reflect, talk about it. You can participate in community events. We just had the National Day for Truth and Reconciliation last week. There were a number of community events or memorials. There's memorials still up. You can visit, you can reflect, you can contribute to change efforts. You can donate, you can support Indigenous businesses, you can donate to us, and we will put your money to the use of supporting the better experience for Indigenous peoples that we see here at Providence. You can be a good colleague to Indigenous people, and you can continue to be hopeful about the change and not get discouraged and not get stuck in that zone of guilt and responsibility. So I will stop there. I appreciate everyone's time, and I hope you took something from this.
Thank you, Sherry and Harmony, for being with us today, for the work you do, and for sharing your guidance in addressing anti-Indigenous racism and the path forward. And thank you to our donors. Because of your generosity, St. Paul's Foundation is able to support Indigenous wellness in meaningful ways, including an all-nation sacred space at St. Paul's Hospital, traditional foods, medicines, and ceremonies, and a brand new Indigenous peer program. There's a QR code on the screen. You can use it to donate, and additional resources will be sent to attendees of this event via email in the coming days. Thank you so much for being with us today. I hope you leave feeling empowered to listen, to learn, and to speak out. Thank you.